Everyone here is okay. Zoom.
You're right. I got that. It's way behind.
Yeah, okay. I'm not exactly sure how to. Okay, I was gonna say, I'm not here. I just. Waiting for IT. We're having some difficulties this morning, so they should be here in just a couple of minutes. So if this ain't right with us, we'd appreciate it. I love it too.
Thank you guys. We're gonna get started. All right. Morning, everyone. Thank you all for coming. Our speaker today is Ron Squires, MD. Our program is underwritten by educational grant through OSU Medical Center, Graduate Medical Education. Disclosure statement has been signed and is on file in the Graduate Medical Education Office. Our speaker today, Dr. Ron Squires, serves as the Chief Medical Officer for LifeShare Transplant Donor Services of Oklahoma. He graduated medical school with honors from the University of Missouri, Kansas City in 1987, completed surgical residency at University of Oklahoma in 1994. During his residency, it took a 2-year sabbatical to do research in the NIH, or as an NIH research scholar, performing basic science research in the areas of tissue ischemia, reperfusion, oxygen-free radical injury at the Oklahoma Medical Research Foundation. He then received additional training in solid organ transplant, organ recovery at the University of Oklahoma and the University of Minnesota, focusing on renal and pancreatic transplantation. He's emeritus tenured professor of surgery at the University of Oklahoma Health Sciences Centers, where he served faculty member for over 30 years. He has served as an active clinician, teacher, and clinical investigator. He's been extensively involved in clinical research efforts throughout his career and also published 31 peer-reviewed articles and 7 book chapters and participated in greater than 50 scientific presentations of his research work. The Cloud CME activity code for today's grand rounds is 3232, and would everyone please welcome Dr. Ron Squires.
Thank you. Sorry for the delay getting started, but we couldn't get the slides and Zoom to work at the same time. Seemed to be one or the other, but not both, but I think we're there. So can't get rid of the bar across the top, fear of losing everything. But I appreciate y'all letting me come in today. The title of the talk, A Physician's Role in Organ Donation, really, it should probably be a hospital's role in organ donation because it's not just the physicians that make all that happen. And what I want to do today, most importantly, is to review with you all the role that physicians have and the hospital has as a partner with your organ recovery organization to maximize this gift that helps save lives throughout the United States. First, LifeShare, we are the OPO, the Organ Procurement Organization for Oklahoma. There are 55 OPOs currently in the United States. Some of them, like Oklahoma, follow a very defined geographic area. Others, not so much. Texas has 3 OPOs. Dallas is within one OPO. Fort Worth is in a different OPO that's based out of Houston. So sometimes it doesn't make a lot of sense. And part of the reason for that is when OPOs were first developed back in the 1980s, as transplant was getting started, OPOs oftentimes got started to support a transplant hospital. Because if you want to be a transplant hospital, if you don't have organs, you're not going to get very far. So an OPO would get started to support a transplant hospital. And then over time, we made sure that OPOs had a geographic area coverage so that no part of the United States went uncovered. So right now, there are over 103,000 people listed waiting for a transplant. 17 people die every day not getting their transplant in time. You all know that there aren't enough organs to go around, and that creates a lot of ethical challenges for us as well. And it's true, it's not just unique to organ transplantation. When we had COVID initially, we didn't have enough ventilators for everybody. Then it created a similar type of challenge because we had to decide who should get that scarce resource and who should not when you can't get it to everybody. If we ran out of antibiotics tomorrow, it'd be the same thing treating soft tissue infections or pneumonia. You can see the various transplants. This is 2024, how many transplants we did in the various organs and how many are on the waiting list still awaiting new transplants. The 173 others include things like composite grafts, like face transplants, hand transplants, uterine transplants now to reestablish fertility and things like that. So this I put up there to show you that with each year, we are doing more and more transplants. And the goal is that we'll do 50,000 transplants in the United States by 2026. And hopefully by the end of 26. And hopefully we'll get there. I think that that's a very makeable goal, but it just shows you that we've had exponential growth since I first started tracking statistics back in 1988. So the top, like I said, our screen there is hiding my title here, but hospitals are actually required by federal law to work with their OPO, their designated OPO. And if they don't, they can lose their Medicare and Medicaid funding, which there isn't a hospital in the United States that can function without Medicare and Medicaid funding. For many hospitals, that makes up 2/3 of their budget. And so the things that the government asks the hospitals to do, and JACO, Joint Commission, also does surveys and makes sure that the hospitals are doing these things, is that there has to be an agreement with every hospital with their OPO. We serve 154 hospitals in Oklahoma. We have a signed agreement with every single one of them, even though many of them will never do a donor. Because a donor, to be a donor, has to be neurologically deceased or severely injured and on a ventilator. And many of our smaller hospitals can't even manage a patient on a ventilator. But we have to have an agreement with every single one of them nonetheless. Hospitals are required to call the OPO on every death and every imminent death, and we'll talk about that a little bit more as it goes along. They are to help facilitate offering donation to every family if there is a suitable donor. And the family approach should be by staff that are trained specifically in how to approach a family, which typically means that that approach is done by the OPO staff, not by the hospital staff, because most of our hospital staff don't want to go out and get that specialized training. That doesn't mean they can't be a part of it, but they're not the leaders when it comes to approaching families. So what triggers a call to LifeShare? Every ventilated patient meeting any of the following criteria: a severe neurologic injury, so a GCS of 5 or less, that's not because you've got the patient paralyzed and sedated for their injury. Brain death testing is planned or you've initiated it. Patient is being made DNR or comfort care is being considered. If you're planning on withdrawing life-sustaining therapy, or if the family just initiates a donation conversation, even if that patient has a high likelihood of survival and recovery, if the family wants to learn more, we are happy to come out and visit with the family about the opportunity. Also, if there's a cardiac death out on the floor, the hospitals all have to notify LifeShare within 1 hour of that death. Because although that donor will not likely be an organ donor, they still can be a tissue donor and help up to 75 different people with the various tissues that can be recovered for tissue transplant. So retrospective studies have shown the timing of approach is really important. We get our best yes answers when donation is discussed after the family has been told of the devastating situation and they've had time to process it. If you approach them before you have that initial conversation, then they may interpret that as you're not caring about their family member anymore, you're more worried about donation. If you do it before they have a chance to process it all, again, you get better consent rates, but not as good as if you give them a chance to begin to grieve and understand the death of their loved one. Who should approach, as I said? Most importantly, it's if we team up with the hospital staff, we go and approach a family. If the donor has not given first person consent on their driver's license, we approach the family and ask them for permission for them to be a donor. There's already a relationship from that family with you all, with the hospital staff. That's very, very important. So the best results are when you all are involved with our OPO staff and you introduce the OPO staff as a member of the end-of-life healthcare team, and then together you go in and explain the opportunity. So Oklahoma registry, we have a driver's license you can now get. You can register when you get a fishing license or a hunting license. or a driver's license. And that registration is valid unless the person pulls themselves off the registry, asks to no longer be registered. It is considered to be a first person authorization, and this authorization falls under gift law. So it's not an informed consent like it would be prior to a surgery. So at the DMV, we don't have to give them informed consent before they say, I want to be a donor. You're essentially acknowledging that upon your death, you'd like to make a gift. So by law, legally, it's the same thing as if you want to gift your car upon your death to your favorite child, that kind of a thing. And by the same token, if you put that in your will, your least favorite child can't challenge that gift. You get to do with your property what you want. And so your surviving family members cannot overrule you if you want to be a donor yourself. Actually, one important thing here I'll put down here, that last bullet point. We need to be careful not to tell the families, we want to know if you want your loved one to be a donor until we find out if that person is already on the registry. It can create a lot of frustration and anger if a family is told, hey, would you like your dad to be a donor? And they think about it and then they say, well, I don't think that's for us. And then we come in and say, oh, but your dad wanted to be a donor, so now your opinion doesn't matter. So it's very important that we not get too far down the path until we're sure what the patient's wishes were. So as I mentioned, hospitals are required by CMS, Joint Commission, and the Oklahoma Uniform Gift Act to do the various things. We have to have the agreement, as we talked about. Hospitals have to have policies and procedures in place for the pronouncement of brain death and for facilitating donation after circulatory death, which I'll talk about in a little bit. We talked about notification to the OPOs, and that's not only after death, but if you are contemplating end-of-life decisions. So it's really important that the hospital team make sure that the donor family understands the concept of brain death or neurologic death, if that is what's happened to your patient. Because uninformed families see the EKG telemetry in the ICU, they see the chest rising because of the ventilator, and they don't equate that with death. So it's very important that they understand that what made their loved one who they were is no longer there and it's not coming back. So that then when we come in and talk about end of life, they're not thinking, well, they're just in a coma. What are you talking about? So we want to prepare the families for bad news, as I said, and we want to make sure that we give them time to process all of that. And our staff at LifeShare have extensive training on how to approach and work with families during this incredibly difficult time in their lives when they've just lost someone. And they are very, very skilled at supporting the families, not only to get the consent, but we support donor families for over a year following their donation. Follow up with them, call them, send them materials, and we actually have an annual meeting where we offer families an opportunity to come in and honor them and their loved one's gift, where we can get everyone who's been a donor over the last year. So what happens when our OPO staff arrive, which that's what it would have said behind the black Zoom box. So there's a team huddle discussion. Our staff come on board. We want to meet with the physicians, with the ICU nurses, and talk about what's next. Is this patient a potential donor or not? Or do they already have first person consent or not? And what is the plan moving forward? Are they going to be—
Morning. This is James Michael Ritz,
RITZE, donor based upon
1-1-852-05-198, 10-16-48.
Experience a cardiac
have
arrest.
Someone contact me and clarify when my neck ablation is scheduled.
Again, who approaches we talked about is very, very important.
As you can. Thank you.
And our best results are when we partner with our hospital team together, as we've already talked about. And we ask, and the government, actually the regulations ask that the hospital teams not be the one to initiate that conversation for the reasons that I've already talked about. But sometimes your families will come up to you and say, hey, what about donation? Maybe someone in the family has received an organ And so they are very interested in that opportunity to pass that gift to the next person. So if they bring up donation, a great quote or great thing to tell them is your commitment's to care for that patient, for their loved one. But you know someone that you can call who can come in and give them that information that they're seeking. That way we keep that disconnect between the hospital teams and the organ recovery teams. So preserving the option of donation. It is very important that we continue the physiological support until we have determined the donor potential. Sadly, it's not that rare that when we come on site because we've been called because the further care has been determined to be futile, they're planning on withdrawing care, that the physician team knew that it was futile a day or two before. So as busy as they are, they've refocused their attention on their other patients. And so we're not managing the urine output anymore. We're not managing the acidosis. We're not managing the euvolemia anymore. And oftentimes in these donors, as they are nearing their death, or if they're neurologically deceased, they may have diabetes insipidus from their brain injury. So they can be putting out a liter and a half of urine an hour. If you don't keep up with that in 12 hours, your sodium's 180, your creatinine's 4, and even though you can try to come in and fix that, it's really hard to get back to where it should be. Prevention is far more successful than correction. So we want to prevent these things. These are the most common problems that we see in severely injured patients that go on to donation. Hypovolemia, for the reason I just discussed, associated hypotension, the hypernatremia. Also, they begin to lose the ability to regulate their temperatures. So many times they become significantly hypothermic and they can become hypoxic if we're not managing the ventilator closely. If you think your patient is neurologically deceased and you are considering doing brain death testing, if they are hypothermic, then you've got to wait, because we know that significant hypothermia can mimic brain death. And so it's important that your patient's temperature be 36 degrees centigrade or higher, and that if they dip below 35, that you rewarm them for 24 hours before you do your neurologic testing. So if we're not paying close attention, it can greatly delay the progress to donation and keep your ICU bed filled another day or two, which you probably would rather have with a patient that has better survival potential. So care of the donor is essentially caring for multiple patients, because a full organ donor can donate up to 7 organs. And as I mentioned earlier, in tissue, 75 different tissues or tissue transplants. So 2 routes of donation. I've talked about them already: neurologic deceased donors, brain dead donors, and DCD. And your role is different from one to the other. We'll talk about that just a little bit. So brain death. It is the irreversible loss of clinical function of the cortex and the brainstem. I'm sure everyone in this room knows that. It is a clinical diagnosis, though. It is not a diagnosis you make because you get a nuclear perfusion scan that doesn't show flow. That certainly is a finding that would suggest that the brain is irreversibly damaged if it has no blood flow. We all know that, but it's a clinical diagnosis. You can't just go order the flow study and say, all right, they're dead. You could order a flow study, tell the family they're not going to survive, but that doesn't meet the criteria to allow someone to be an organ donor. They need to be in a coma or be unresponsive, which also means that if they're neurologically deceased, they need to be on a ventilator. We have had, on rare occasions from small hospitals, calls coming in that they have a patient who's brain dead, but they're not on a ventilator. Well, that can't happen. If they're breathing on their own, they're not brain dead. So education is in order when that happens. We'd like to see that there is some explanation for why the patient's neurologic status is what it is. It makes me very nervous when the CT of the brain looks completely normal. We don't really know why they have no brain function. We may do a perfusion scan, we may see perfusion in there. So we don't really know, because one of the concerns there is perhaps there's a drug on board we don't know about that's mimicking brain death. And if that's true, that may offer the opportunity for a full and complete recovery. And we have had that happen a couple of times where we've gone on site because brain death testing was done and they were determined to be brain dead by their clinical team. And we couldn't find a good reason. And we started doing additional blood work and drug levels. One time, a benzodiazepine overdose, patient fully recovered and left the hospital normal. And one was a tricyclic antidepressant overdose. Again, their neurologic status at the time was exactly that of brain death, but it was due to a transient overdose that had the opportunity for recovery. So brain death declaration, we got the definition of brain death in the United States back in 1968 with Harvard's mission on brain death as a definition. And we've been using brain death as a means to recover organs since that time. The most recent update on how to properly pronounce brain death is published here. It's in the American Academy of Neurology journal and in neurology. And this was a joint paper by the critical care medicine, by the American Academy of Pediatrics, and neurology societies together to update what is best practice when it comes to donation. It's a 21-page paper. If you are in a position to pronounce brain death, this is something you really ought to read once. It's very important, and we're happy to let teams know when we're on site if there's anything that we have a concern with, since we do this every day. But the stakes here are so high, we don't want to inappropriately pronounce someone dead when they're not. So we follow, the OPO follows these guidelines. I occasionally will have a physician somewhere in Oklahoma, usually they're older, have gray hair like I do, saying, I've been doing this for 40 years, and when somebody's dead, I know they're dead. And we're not there to challenge their clinical judgment. But even though the patient very well may be dead, they've got to go through the proper steps for us to be able to recover organs. We can't just say, well, yeah, I think you're right. For the hospital team, the physicians, we need a clear note written once they have done the things that determine brain death. That note needs to include the tests that they've done. Did they do doll's eyes? Did they do cold calorics? Did they check for a gag, a cough? They're not assisting the ventilator. They are not responding to pain, documenting all those things. If they did an apnea test, did they do, documenting the apnea test? And then based upon those findings, write a conclusion that says, this patient has had these tests and has been pronounced brain dead at this time on this date. At that point, they're deceased. That's what goes on their death certificate. And at that point in time, that patient, if they're a donor, becomes a life share patient. You all are done. You don't have to write any more orders. You don't do anything because they're deceased. We're taking care of a body, getting it prepared for organ recovery. Every expense associated with that is covered by life share. So essentially, the clock stops on any bills that the patient's family might get, and we're covering everything. If we do any tests before this is done, we still pay for those too. So if we want to get a CT scan of the abdomen, but their brain death testing hasn't been done yet, if we ask for it, we pay for all of that. So the families are not given any kind of an economic burden in order for their loved one to be a donor. So clinical prerequisites to doing brain death testing, we talked about already. Temperature and making sure there's no drugs on board that might mimic brain death. We want to correct any severe abnormalities that might create a mimic for brain death. Make sure, obviously, that they're not on neuromuscular blockers. And we want the mean arterial pressures to be greater than 60 to make sure that the hypotension isn't causing neurologic dysfunction. So the establishment of coma, clinical diagnosis, no eye opening, no purposeful movement. Spinal reflexes, though, may still be present. So sometimes, if you jostle the bed or hit it, you'll see a spinal reflex. That doesn't involve the brain at all. That's a stimulation from sensory up to the spine, right back down to the motor system. So we can get spinal reflexes. And sometimes the spinal reflexes are interesting looking, and especially to an untrained family member. And so it's important that we educate them. And if we are certain that this patient has experienced neurologic death, sometimes then we will, if we've got the families at the bedside, which often they are, they want to be there right to the moment that the donation takes place. We may actually give them medications to help subdue spinal reflexes just for the family's sake. So we talked about all this already, so I'm not going to go through that again. Apnea testing. Apnea testing isn't that hard, but it's a source of a lot of confusion. And the key things to do it right are, one, make sure that you've corrected the PCO2 before you start your apnea test. Many of these patients, because they've suffered a neurologic injury, you may be hyperventilating them on purpose. So their PCO2 may be 25 because you have intentionally hyperventilated them. We need that CO2 at the end of apnea to get over 60. So if you're starting really low, that means they have to be off the ventilator for a longer period of time to hit that 60 mark, and they may not make it. So we want to correct that CO2 as a baseline before we start the apnea test. We need to pre-oxygenate for at least 10 minutes. So we want to turn the FiO2 up to 100%. And if we do that, along with when we take them off the ventilator, putting oxygen tubing, just cut it off, put it down the endotracheal tube, turn it on high flow, 6 liters or greater, just sitting in there, along with pre-oxygenating, they don't typically get hypoxic, even though they're not on the ventilator. For even 10 minutes without breathing, they will maintain their PO2s. The times that they don't is when they have underlying lung disease. They've got a severe pneumonia or terrible lung contusions or COPD or whatnot, and apnea just may not work. And then we have alternatives. Where I've put the word "and," this is really, really important. Now, during the apnea, you've taken them off the ventilator. You're looking to see if their chest moves at all. It's important to take them off the ventilator because if you just turn down the rate to 0 but leave them on the circuit, sometimes the ventilator is set so sensitively that it will trigger itself. You know, you hit the bed or something and it triggers and it thinks the patient initiated breath and then it gives them one. And so then you're confused because you're not sure if the patient did that or if the ventilator did that. There is, regarding CO2 at the end of the apnea test, to show that the CO2 rose enough that if this patient had brainstem function, they should have taken a breath. Same thing as if you hold your breath right now, pretty soon you just have to take a breath. That's what we're doing here. We're testing that. So for any of us who start with a normal CO2, if your CO2 gets up to 60, it tells your brain, take a breath, and you do. And that's the basis of this. But if you're a chronic CO2 retaining COPDer, you may live with a CO2 of 50, 55 on a good day, on a normal day. So your brain has become accustomed to an elevated CO2. So looking to get it over 60 isn't good enough in that case. So the end point for your post-apnea test blood gas needs to be at least 60 and be greater than 20 above whatever their baseline is on a normal day. We see confusion because some of our physician teams will think it has to be over 60 or it has to rise by 20. But if you start with a PCO2 of 25 when you start your apnea test and it goes up to 47, that's not good enough. It went up 20, but the 20 rule is only for people that are chronic retaining COPDers. Confirmatory testing, if we can't do an apnea. Some of our patients, their lung disease or their lung injury is so severe, trying to do an apnea, they will get hypoxic, they will get hypotensive, they will get arrhythmias during that apnea period, and we don't want to initiate a cardiac arrest. So there are confirmatory tests we can do in addition to the clinical exam in place of the apnea exam. The one that's done most commonly is a nuclear perfusion scan because most every hospital has that opportunity to do it. It's pretty easy to do. It's easy to interpret. You can do transcranial Doppler assessment for blood flow. You can do 4-vessel arch arteriograms, and that's accepted as well. I put an asterisk by CT angios and MRI angios because although they can show you that you don't have flow, if you've done a contrast CT of the brain or contrast MRI, those have not been validated in the setting of brain death testing. So although they probably are going to show flow or no flow, they're not considered to be acceptable for confirmatory testing. Something new in the guidelines that I showed you earlier from the AAN on brain death testing in 2023, that was new in 2023, is they took away EEGs as a confirmatory test. It's no longer here. It was a confirmatory test until 2023. They took it away because they were concerned that an EEG does not assess brainstem function thoroughly enough to be used as a confirmatory test. So that's no longer an option. So we've already gone through most of this, so I'm going to jump ahead. Family communication. Again, it's important to introduce our team as part of the end of life team, and that we are going to tell them about an opportunity for their loved one to help positively impact the lives of other people. We want that collaborative approach, and we want a seamless transition from saving their loved one's life to now getting to focus on saving other lives. So, DCD, the other opportunity. So DCD donation after circulatory death occurs when the patient doesn't meet that strict criteria for brain death determination. So if you've got a patient who's not brain dead, doesn't meet that criteria, but they have no meaningful opportunity for recovery, you're going to talk to that family about limiting care, switching to comfort care, and end of life situations. In that situation, our patient still can be an organ donor. What is done is that once you've had that conversation with the family and that you all and the family have agreed that's the right thing to do, then we want to talk to the family about the opportunity for donation. It's very important that they have that conversation about end of life before we talk about donation again. We don't want to create an appearance that we're trying to facilitate donation by making the decision to go to end of life. That decision of end of life was going to be made whether they're a donor or not. So we've talked about all of that. So when you withdraw care, you've determined that care is futile, you're going to withdraw care, you're going to extubate your patient because they have no opportunity for recovery. That can happen in the ICU, it can happen in the recovery room, it can happen in the operating room if this patient is going to be a donor. It really depends upon hospital policies. It depends upon, sometimes the families want to be there and see that last breath after they've been extubated, in which case perhaps the ICU makes more sense. You have some hospitals where the ICU is on a different floor and a different wing than the OR, in which case then the ICU doesn't make a whole lot of sense. We want to do that withdrawal of care in the recovery room or in the operating room to facilitate rapid transport of the patient after death to the operating room to begin the recovery process. When they withdraw care, in order to be a donor, the patient needs to experience a cardiac arrest within 2 hours. We'll have teams there on site, our team's there, our surgeons are there, the operating room's already open, ready to go. We withdraw the care. Not everybody will experience a circulatory arrest in 120 minutes. We know when we evaluate the respiratory status of that patient and the hemodynamic status, the likelihood of them arresting, if they're on 4 pressors and they're on 80% FiO2 and 10 a peak, yeah, they're going to arrest really quickly when you take that away. But if they're not on pressors or they're not on a lot of ventilatory support, they may not arrest quickly. Sometimes they do. Sometimes they surprise you. So we're going to pursue every donation opportunity, but some of them won't expire in a time that allows them to be a donor. If that's the case, if we go the 120 minutes and they still have a pulse, they're still breathing, then they're no longer going to be an organ donor. The patient is still under the care of the hospital team. You all will have talked with the family ahead of time, and we'll be a part of that, talking about what happens if they don't rest. Talk about where we're going to move their loved one, probably up to the floor because they don't need an ICU bed anymore. And they continue to be cared for lovingly up on the floor until they do experience their cardiac arrest. And then the hospital needs to notify us within an hour of that arrest, because although they're not going to be an organ donor, they can still be a tissue donor. So DCD candidates, some examples of common illnesses that would allow you to be a DCD donor. Most of them have suffered a severe brain injury. It's a big stroke. It's an intracranial hemorrhage. It's a trauma to the head, but they haven't quite progressed to complete brain death. Sometimes, though, it's just end-stage lung disease, and you can't get them off the ventilator. And after you've tried for a couple of weeks, they're just not coming off the ventilator. The family says, Uncle Joe did not want to be trached and on a ventilator the rest of his life. And so you make those end-of-life decisions. One of the most difficult patients that I think we have, just emotionally, are high cervical spine injuries, C1, C2 fractures. They're a high quad. They can't do anything but blink, but they're neurologically intact. Sometimes those patients will make a decision they don't want to go on in that kind of a condition. In those settings, we'll often involve the ethics group and the chaplain services to make sure that this is a decision that they have been able to consider carefully, give them time to really consider that. But if that's their decision, that's their decision. So the DCD process, and when I told you earlier, for the neurologically deceased patients, once you pronounce them brain dead, you're done. They are our patient. We write all the orders. We take care of them. We get them to the operating room. We place the organs. We facilitate the recovery and the transport of those organs. If it's a DCD donor, we don't write any orders on that patient because they're a living patient. We may ask you all, can you order a CT scan? Because we'd like to get a CT of the abdomen. Could you order lab tests for us? Could you correct the hypophosphatemia for us? We'll ask all those things, but we can't write any orders because the patient's still alive. They're alive up to the point they've experienced cardiac death and you've pronounced them dead by cardiac criteria. At that point, then yes, we do take over. So, and that's what I just said there in bold. You all still take care of the patient, do everything for the patient. And you may tell us, I don't want to do that for my patient. I don't think that's a good idea, my patient. That doesn't happen very often, but sometimes maybe we want to get a CT scan, but they're so fragile, you're worried about sending them down to the radiology suite because they're that fragile and you're worried they're going to experience instability. If that's the case, fine. You just tell us, I don't think we should do that. We don't do it. They're your patient. We may ask for cardiac catheterization. You know, if it's a young trauma patient, 35, 40-year-old that smokes a couple packs a day, he's probably going to be a good heart donor, but our centers are going to want an angiogram to make sure he doesn't have premature coronary artery disease. So he's a living patient. Is he going to directly benefit from that heart cath? No, but he can help save a life in the process. So those are things, if that's a setting, then we will get consent from the family for the heart catheterization. Any kind of a procedure that would require consent in any other situation, we'd ask the family for consent as well to do that procedure because, again, the patient is alive. So we talked about that already. What do we do if they don't arrest? Most of our hospitals have a 120-minute maximum, and that's what most of our transplant centers want also. Some are still at 90 minutes, but we're working toward the 120. And 120 minutes, if they've been agonal for 120 minutes, those organs are probably not going to be transplantable. But oftentimes, they'll be pretty stable for the first hour, hour and a half, and then they just crash and experience circulatory arrest. That's going to be fine, because then we don't have 90 minutes of ischemia. We have 3 or 4 minutes of ischemia. So what do? Our OPO coordinators, they evaluate the potential donors for suitability. We may come on site and say, oh, they've got this in their medical history. They're not going to be a donor. A prior cancer history of melanoma or breast cancer, if it was invasive breast cancers, or rule outs, because those cancers, even when we think the donor is disease-free, can recur in the recipients many years later. So those are rule outs. There are certain infections that'll be rule outs, but a lot of them are not rule outs. But we'll look to see medical suitability. As I said, our staff support the families. We present that opportunity for donation. We do the authorization if it's not first person. We manage the donor in the ICU if they're neurologically deceased. Our staff then are trying to find homes for these organs ahead of time. Ideally, we want a transplant center to have said, yes, this is going to be a good fit for my patient before we ever get the organ recovered, so that we minimize the ischemic time of the organ. And then we're responsible for getting that organ to that transplant center, which might be just down the street, or it might be all the way across the country. All right, we've gone through all of that. So does it seem like we've had more DCDs of late? If it doesn't, you're not paying attention, because we've had a lot more DCDs. So this is experience in the United States, 2010 to 2024. And what we see is that although brain dead donors have gone up just about 39% during this time, the brain dead donors are the orange bars. The DCD donors have gone up over 670% during this 15-year time window. DCD is really responsible for our increases that I showed you on that earlier slide about transplanting more patients every year. And in fact, last year was the first year that the number of brain dead donors in the nation actually declined year over year. And this year, they're estimating that we will do about 1,000 fewer brain dead donors this year in the United States compared to last year. And we'll do about 1,200 more DCD donors this year in the United States compared to last year. Part of that is probably because we're starting to get a little bit of a handle on the opioid epidemic. So as we do that, we're seeing fewer narcotic overdose deaths. Narcan is much more readily available. We're saving lives, which is the most important thing by not having our patients progress to being a donor. But many of those were neurologically deceased donors in the recent past. So donor demographics during the same 15-year period by age. You can see here in the square there to the right that our biggest increase in donors is in the age group over age 65. And that the next highest is in the 51 to 65 range. And that represents a majority of our donors, the red bars, because that's an age where we're starting to see strokes, heart attacks, lung disease progress, and that type of thing. So our donors are getting older with time and becoming more medically complex. We're also able to utilize organs from older patients, and I'll show you that technology here as we wrap up. So what's LifeShare's experience? Here's LifeShare's experience on the left side. The green bars are neurologically deceased donors. And this year we're annualizing in 2025 to have 110. So quite a bit less than we did last year. Last year was a record year. And you can see our DCD donors have gone up dramatically over the last 7 years that I've shown here. And then we're annualizing 159 DCD donors this year. So DCD, our experience in Oklahoma is mirroring that of the nation. So we're able to use more DCD donors and older donors because of some new technologies. And this is going to be the last thing that I wrap up with and show you. We have hypothermic machine perfusion of kidneys. There is a liver pump that's in the final stages of being FDA approved so that we can run a cold solution through the organs to try to flush out bad metabolites, keep cellular metabolism slow, and it decreases end organ dysfunction when we go to transplant the organ. We have normothermic machine perfusion of organs where we perfuse the organs with oxygenated blood at 37 degrees. So the organ thinks it's still in the body. And that has helped us a lot at being able to better assess marginal organs. The organ took a hit in the donor because the donor was really sick. You know, the LFTs are high, the creatinine's up, the heart, in the United States, the first DCD heart transplant ever was about 5 or 6 years ago. Because if you have to wait for the heart to get ischemic enough that it stops beating to be dead, nobody wanted to put that heart in somebody else. But we knew that some of those hearts were probably still going to be good, especially if they arrested pretty quickly, if they didn't have a prolonged agonal time. But we had no way to know which ones to use, which ones not to use. Now with normothermic machine perfusion, we can put that heart on a pump and it starts beating again. And we can look at the contractility of the ventricles and see that that heart has not been significantly damaged by the ischemic time and use that heart. And then lastly, we have normothermic regional perfusion, which is the same thing as our normothermic machine perfusion, but it's still in the donor's body. And I'll show you some pictures of that. As opposed to taking the organ out and putting it on a machine, we actually reperfuse the body, limited parts of the body. We're not reperfusing the entire body, but it's essentially ECMO on a confined area. So it's abdominal ECMO, or it might be thoracic and abdominal ECMO, but obviously we don't want to do ECMO of the brain, and we don't. So this is a picture of the ORS LifePort pump. We've had these for about 15 years. We have 14 of them at LifeShare. This is a hypothermic machine perfusion of the kidney. You can see the kidney in that basin at the top. Okay, that didn't work anyway. So it's at the top and it perfuses at about 3 to 6 degrees centigrade. And we can measure flow, we can measure resistance to see if that kidney looks like it is going to perfuse well in the recipient. So it has clearly been shown to reduce delayed graft function when we use this technique. It allows us to perhaps do transplants during daylight hours, which our transplant surgeons love, as opposed to needing to get it in as quick as possible. When it's just sitting there on ice, the clock is ticking. The clock is still ticking, but this adds to 24 extra hours. So if that kidney rolls in at midnight and you've got a 3.5 hour cross match, you don't have to be in the OR at 3:30, 4 o'clock in the morning. You can schedule that for a 7:30 a.m. case, which makes everybody happier on the OR staff. Our surgeons, we get a kidney, the donor was really sick. The creatinine is 9. They're making that, the kidneys aren't making any urine hardly at all, but it's a 35-year-old. And we do a kidney biopsy, and the biopsy doesn't show any chronic disease. It's all acute tubular necrosis. Is that kidney going to work or not? It's not working in the donor, but we can put it on this pump. And if we get good flows and low resistance, that's going to be a kidney that everybody's going to want to use, because that tells the transplant center that injury was transient. You just put that kidney in a better environment and it's going to get better. It was all the donor's environment that caused the dysfunction. So this just shows the use of the kidney pumps. Our data in Oklahoma is up there in yellow and the national data is in blue. You see, we have been increasing the use of the pumps, but we were already using them over 70% of the time way back in 2016. The national use, because it does add extra expense, really began in that area that's KAS 250. KAS is Kidney Allocation System 250. That's 250 nautical miles. We used to allocate all of our organs local, which meant your own OPO, which would have been in Oklahoma. That got priority. Then regional, which region 4 is all of Oklahoma, all of Texas. And then if nobody could use that organ locally or regionally, then it went out nationally. But there was concern that that system might disadvantage some people, some patients, especially on the East Coast where you might have 2 or 3 OPOs within 100 nautical miles of each other. It kept a patient literally across the river from being ordered or offered an organ, where they might actually be closer to the donor hospital than somebody else in their local service area that was getting the offer. So now it's based on geographic circles. So 250 nautical miles from the donor hospital. When we did that, it was modeled, determined, it looked like it's going to be more fair. It probably is more fair, but it means we're flying a lot more organs. So now these organs are being transported longer distances far more often. And so that's why you see the national data using these kidney pumps more, because there's more ischemic time on the kidneys. And everybody realized that the pump can help overcome that added ischemia from this new system. So next steps, hypothermic oxygenated perfusion. So this is adding oxygen to the machine. That pump already exists. It was made in Europe and is available. And then ultimately, we'll probably be doing normothermic machine perfusion of kidneys. That technology is only in research right now, and there is no clinical product, no clinical pump to do that just yet. We can pump livers. LifeShare, the Oklahoma OPO, was the first OPO in the United States to use the OrganOx Mitra. We were the first ones to use this after the FDA approval. That was about 3.5 years ago. It has greatly increased the utilization of DCD livers. We've had a 90% increase in successful placement of DCD livers since we started using this pump. And we can perfuse this liver. The FDA says up to 12 hours. I think our longest liver that we've pumped and successfully transplanted was 19 hours. And again, this lets us look at liver parameters. We measure lactate, we measure pH, we measure glucose metabolism while it's on this pump. So we can see if that liver is really doing the metabolic things we want it to do when we transplant. And some of the livers, when we put them on the pump, they don't perform well. And those livers aren't going to be transplanted. So it gives our transplant centers more data to decide, is that liver the right liver for my patient or not? We can do something similar with lungs. We don't use blood. We don't use oxygenated blood. We use a solution called steam solution. But we can put it on. You can see the lung there under the dome, that sterile dome. We put it on. We perfuse the lung with a perfusate that's oxygenated. We can measure the PO2s. We can actually put diuretics in the system. Or we can put anticoagulants in the system, rather. We can change pressures to try to pull off some fluid if the lung was a little edematous in the donor. We've actually had some lungs that had PEs that we're able to put anticoagulants in the perfusate and go on and get to transplant the lungs by helping to, with thrombolytics, dissolve the emboli. And then heart, this just shows the Transmedics OCS pump, heart on a pump. Literally it's beating. Tried to upload a video into this and it didn't want to run very well. But yeah, that heart is just sitting there beating just like any other heart you'd see in the chest with an open chest. so they can see how that works. And that has really revolutionized DCD heart recovery. And then lastly, normothermic regional perfusion. We have abdominal and thoracoabdominal. This is just a picture of abdominal NRP after the patient. We don't do this in a neurologically deceased donor because their heart's still beating. So when we take the organs out, they're getting normal perfusion right up to the moment we remove them from the donor body. But in DCD, after the patient's experienced the cardiac arrest, we want to wait 5 minutes, reassess to make sure that that cardiac arrest is permanent, that they didn't have a reanimation of their heart. At that point, then they're ready for the recovery. So we rush to get the recovery. Usually we can get the organs out in about 30, 40 minutes, but we can cannulate and get started on normothermic regional perfusion in about 5 minutes. So we can minimize that ischemic time of the organs. So we cannulate, we cross clamp the aorta if it's abdominal NRP at above the celiac, so in the upper abdomen or in the lower chest. Or we can put in an occlusion balloon because we don't want to perfuse the chest, or really we're wanting to make sure we don't perfuse the head. And then run warm oxygenated blood. We can measure blood chemistries during this time. This technique is usually done in the OR for about 90 minutes. And we look to see what the chemistries are and then recover organs accordingly. It's been clearly shown that in DCD, NRP greatly decreases the ischemic clangiopathy that we would see in some DCD donors. And when they get that, when your recipient gets it, it's devastating because an ischemic bile duct isn't just a localized stricture. It looks, there's nothing but another transplant that's going to fix that because all of the biliary system throughout the liver gets strictured. And so they get jaundiced and they go into liver failure from cholestasis. Thoracoabdominal, same exact concept, but here we're going to cross clamp and divide the great vessels going to the brain. We clamp them and then we open them distal to the clamps so that we make sure there is no flow, no pressure in the vessels going to the brain. Studies have been done to show there really aren't significant collaterals, but early on in the process, people worried, would there be collaterals that could somehow find the brain and perfuse the brain? That's not really been shown to bear out, but also when you transect the great vessels on the other side of the clamp, you know what the pressure is because you're just getting these dribbles coming back. So you know that brain is not being perfused during this process. This allows us to do heart recovery. Interestingly, abdominal organs greatly benefit from NRP. Heart greatly benefits from NRP. Lungs don't really need NRP. So our lung teams like to get in there and get the lungs out before we do this. They don't want to subject their lungs to 90 minutes of NRP. So that becomes an ongoing negotiation in the operating room as to who's going to do what and when. So in conclusion, donation opportunities are increasing. We're still not meeting the growing need. As we get better at doing transplants, we're listing more people. We're listing people now that would have been considered too sick to transplant 10 years ago. So that's why even though we're doing more transplants, we're not really making a dent in the donor list, but we're now able to offer this to more people and save more lives. It's critical that we have a strong partnership between the OPO and our donor or hospital partners. Everything I've told you here, without it, we're not going to be successful. And these new perfusion technologies are allowing us to successfully recover organs from donors that 5 years ago would not have been considered to be a transplant candidate. And that's the only way we're going to grow the organ pool until we can master the xenotransplantation, which is still quite a ways off. It's said xenotransplantation is 10 to 20 years off. They've been saying that since the 1980s. We may be a little closer than we were, maybe 10, but we're still not there yet. And I know you all have heard those rare cases in the news, but we don't have any organs that have survived a year yet as a xenotransplantation. And I would be happy to answer any questions. Talk about xeno. We didn't have time. Any questions about that? Controversies? All right.
What organ do you think will be first for xeno?
It's going to be kidney, and that's where they've all started. I think you could do heart. A pig heart is pretty similar. One of the problems you run into though with heart is pigs can get really big. And so how do you get the heart to quit growing? Because one of the concerns is you put a heart, you size it for your patient at the time, but will it continue to grow in the human recipient to the point then that it doesn't work? So they're looking at, is there anything we can do knockout wise to try to, with knockout genes, to try to help keep that from happening? The kidneys, we really don't have that issue. And so that's where it's going to start. We've got an endless supply of pigs. They are now able to knock out a lot of the antigens that were causing hyperacute rejection in the pigs. And the pigs are being raised in facilities that are amazingly germ-free because we want to make sure that we are creating transition of infections from pigs to humans, because we all got to enjoy COVID, which we think was a crossover from bats or who knows what. There's a lot of theories there. But swine flu is an example of a crossover, and we have to be very careful when we start intentionally putting animal organs into humans that we don't have unintended consequences with new infections that the world's population has never dealt with. Yeah.
I have one thing too. You got a patient who's a donor, and the family's made the decision to do comfort care.
Yes.
And they're ready to withdraw care. If you guys come to us and you say, this patient's a donor, we're gonna keep them alive for 3 or 4 days.
We don't always get to do that. We ask if we can do that. But we have families
But
that,
if the family says no,
if the family is giving consent, we will go with what the family wants. If it's first person consent, then we will be a little more persistent in saying we need this extra time to maximize the gift that your loved one wanted to make. But it's not uncommon that when the
I'm just
family
saying this is
decides,
what I've experienced.
Yes.
is This family had the check mark on the donor license. But, I mean, the patient had the check mark,
yes,
right?
if that's the case, we try very hard to honor that patient's wishes and make sure the family understands that even though we know they're emotionally exhausted, and they always are, it is not rare for us to come on site when the decision is made for comfort care because they've been at the bedside for the last 2 weeks. And now that they know this isn't going to have a good ending, they're done. And they just want it done. That's a very common reaction. Many times we can help overcome that by helping to educate the families that 1 or 2 more days may result in 1 or 2 or 3 extra organs that can be successfully transplanted. But we did a donor 2 weeks ago that we were in the OR 4 hours after we got on site. Now, when we do that, we're only going to be able to get liver and kidneys because we don't have time to have HLA back. We don't have, time to allocate. So what we did in that donor, because that's what the family said, we want to be done by this time or it's not going to happen. And they had provided the consent. So if we can't meet their criteria, they can withdraw consent and we're done. And we don't want that, but we also want them to understand the implications of this. Because although we understand that they're just done, these deadlines are arbitrary. They're just because they're exhausted, they're ready to go. And our staff are very familiar with that and they're very good at working through that. But in that case, 4 hours, we withdrew, rushed to the OR, we put the kidneys on the pumps, we put the liver on the pump, and then that bought us time to get our infectious disease testing back, to get our HLA back, make sure the donor didn't have HIV, didn't have any things that would be a contraindication, and then we allocated. So we ended up allocating 6 or 8 hours after the organs had been recovered.
Yeah, so how long does it take to get all that back, that testing back?
We get the initial infectious disease testing back in about 6 hours. Depends on where the donor is, because we run it all at OBI in Oklahoma City. So if it's a donor here in Tulsa, we're driving the specimens down the turnpike to OBI. So it's 6 hours once it gets there. So here in Tulsa, it's going to be a little over 7 hours to get that back. If we have a recipient that is sensitized, recipients can have antibodies to human antigens. And they run PRAs, panel reactive antibody tests to see how sensitized they are. Commonly, they get sensitized, mothers will, from having several babies. Blood transfusions can sensitize. Prior transplants really can sensitize. And your recipient may have certain antibodies that if you give them an organ with that antigen, they're going to just have a hyperacute rejection, destroy the organ literally before you get the wound closed. And so that test can take 4 hours to get that back. So when we're placing the organ, we may be sending blood to a transplant center so they can do that test ahead of time to make sure that this donor doesn't have any unacceptable antigens so that they go ahead and say, yes, we want to use this, or no, we don't. So that adds more time also. Sometimes we need more time because we're trying to diurese the donor body because the PO2s aren't good enough right now. We want a PDEF ratio, a pressure to FiO2 ratio, to be at least 300. So on 100% oxygen, the PO2 needs to be at least 300. Ideally, it's going to be over 400. Sometimes we need to work on correcting atelectasis, diuresing the patient, better chest physiotherapy. Occasionally, we'll even want to prone a patient to try to do that. That takes time. And we might be able to place the lungs if we have time to do that. For the heart, most of our heart centers want to get an echo off of pressors. They want to see what that heart can do when there's no pressors on board. So we may need a day to get the hypovolemia fixed so we can wean off the pressors, so then we can get the echo. Because if we just rush in and get the echo the first hour we're there, then that data is not helpful. And the transplant centers are going to say, call me back when you get one off your pressors. So those are a lot of the things that we're doing that take time. And some of those are just fixed times that we have no control over. They may limit what we're able to successfully recover for transplant. Great question. All right, well, thank you all very much.
Yeah, John,
Whatever you have, it doesn't have to be the next one.
And so I primarily talked to them.
No, it's all this.
Off the bat. The clinical referral criteria. So it's all of these, and just talking to them about when a patient meets certain criteria that they make that referral call. And so that's primarily what I'm kind of talking to them about. But yeah, and then we have different, like throughout this past year, we have that were available for physicians and nurses, RTs, and they can get CE. So we try to provide as much education as we can.
We know, I told you that we get.
Yeah.
So I had.
At St. Francis?
Yes, they're on 3 towers. So
Okay.
they're from ICU. So my daughter, she's been an RN. So she's, she's a CCRN, so she has a lot of experience. My son, though, was a baby nurse.
Oh, yeah.
So I just, especially her brain, about how much she understands about all of that, on the, a few days before, and why they're doing that, because I'm sure my son is. Because, they both are night nurses, and they kind of both call me in the morning. Because
Sure.
they do.
Yeah.
And so, they'll talk about, this could be a great life share candidate, and as night nurses, they have a tendency to really have a bond with this family. So I was just wondering, how much do they understand about how important it is to maintain all of that in those few days before?
Right. Right. So at St. Francis, they have in-house coordinators. So Kristen, Connor, and Spencer and then overnight is Parker, I believe. And so, I mean, they definitely can, answer questions and talk to them about something like that. But we do have education opportunities throughout the year with webinars. As a matter of fact, our webinars, they can, they're across the board, all sorts of topics, but about donation, and they can still get points as an RN or education for a year after the webinar was originally posted. And so I can get you a list of those.
Yeah, I just wondered because I mean, like the nurses, and I can see that having nurses that are really educated.
Yes, for sure. Oh yeah, our nurses are right-hand man, so for sure. But I'll send you a list of those webinars because it might be something that they, I mean, if nothing else, it's just continuing education and something they might be interested in.
Well, and I coordinate grand rounds, so I mean, I think that this also like Dr. Cook, Kathy Cook was faculty member, one of the faculty members that was talking last, and so they have a lot of times. Dr. Cook will have a good idea what can be really beneficial with these residents to hear.
Yes.
So if it's something that you want to do in the future, I can always get you on the schedule real quick, because it's probably something that our residents and stuff need to hear. And like I said, we have 34 programs throughout the state, so we cover a good portion, especially in rural Oklahoma. We have programs, and I mean, I don't even remember how many different specialties we have right now. 14, 15, something like that. So, so of course we're mostly IM and FM, but there's OB and surgery and cardiology and ortho, and we have psych, all of those. So we cover a pretty good basis, and we are about to open a neuro program, and there's a lot of different ones that are in the works over the next 3 or 4 years. So hopefully that will even be more beneficial. But our largest group of residents are here in Tulsa, but we have them in some other urban areas here in Norman and Stillwater. But a lot of our programs are like Tahlequah and Tallahena and Durant, Chickasaw. I mean, so we're literally all over the state, and our programs just keep growing. So we do have a lot of those outreach to us.
And I mean, like, Tahlequah,
They do an amazing number of numbers.
they really
For
do.
their size. They, per capita, they're huge. To not be a big trauma center or anything, there isn't anybody in a similar environment that's even close.
What about like a Cherokee Nation?
We have not gotten any donors I can think of in the recent past, but Tahlequah will have 3 or 4 donors a year, which is amazing.
That community.
Yeah, I mean, most of our big donor hospitals are big trauma centers, big neuro centers, because that's where the majority of our donors are. And as I said early, to be a donor, you've got to be ventilated. You got to be in the ICU with a ventilator, and that a lot of our small hospitals don't even have an ICU.
Well, we do have an IM program at Tahlequah, and then we have a family medicine program at Cherokee Nation at Hastings, and we also have an IM program in Stillwater. So I don't know if you
Stillwater's for mines because it's
Stillwater does some donors,
Yeah.
but what? In all fairness, too, you can't just look at the hospital and say, well, this is the few donors you did, because a lot of the time the hospital is transferring those patients to a tertiary care center, so they don't get credit for that patient, even
and a
though
lot of those patients come here.
they originated, in Stillwater, but then if the donor recovery wasn't performed at Stillwater, they don't get credit for that. And honestly, sometimes we will transfer a donor from a smaller hospital to a tertiary care center, especially if they're brain dead, because they're deceased. But sometimes we'll talk to a family and ask if they will allow us to move a DCD donor, because they may be in a hospital that isn't gonna have the resources to do everything we need to do. And then, you know, if we've got teams flying in on private jets, excuse me, for park loans and whatnot, you know, the nearest corporate, airport may be an hour away. And then you've got to fly them in and then put them in an ambulance and drive them and it's, so it makes more sense sometimes to move one donor than it does to work out the logistics for 20 people.
Well, if you ever need any contacts, like in any of those smaller hospitals too, you know, I can put you into touch with, you know, like our program directors and different people that are at those people, because I am sure that, you know, having the residents really understand. It's going to help, whether it's now or in the future.
Right, yes.
And these residents are going on. So,
Some of the critical care attendings that I speak with will say with some frequency that organ donation is not taught in medical school and it's not taught in critical care fellowship like it should. And so you get these physicians that are then out there in practice, and now, you know, organ donation is, you know, a real part of their practice if they do critical care medicine. And yet they were never trained in it. So it ends up being, we end up trying to train them at the bedside.
yeah, I can see that. Well, what I was asking Jane earlier was especially like from a nursing standpoint too, because I have a couple of my kids that are neural trauma nurses. And so so I'm just like, I'm my daughter who has more experience, I bet, understands a lot better about why she is doing some of the stuff to keep some of these people that they know are not gonna live, you know, stable.
Just
the
supporting
DI stuff like that.
physiological.
But I'm like, I bet my son really doesn't have to, you know, because like I said, he's a baby nurse, so, you know, and so I'm like, you know, they develop such bonds with these people, especially some strong cases. So anyway, I don't
Hit the
know.
road, I've got a 10 o'clock.
Thank
meeting.
you so much.
Thank you.
I apologize for all the issues and somewhere along the way.
Yeah, even the black bar went away, I don't know why.
Yeah, all of a sudden it just
Notices.
I know, I don't know
It
why.
makes no sense.
I didn't do
Anyway.
anything that I know of, but
Yeah. Did you get your thumb drive?
What's that? I did get my thumb drive and I already deleted the file I put on the
Okay.
desktop, because they don't want that on there forever,
Okay.
so.
I appreciate it. Thank you so much.